Welcome to the debate. Today we are dissecting a medical paradox that's hiding in plain sight. It's a line of text that exists in almost every single electronic medical record in the Western world. It's designed specifically to keep patients safe, yet paradoxically, it dictates life and death decisions that often lead to worse outcomes. I'm talking about the allergy list.
Right, it's the do not touch sign of medicine.
Exactly. But here's the problem. Statistically speaking, that sign is a lie. We know from the source material that up to 90% of the entries on these lists, specifically regarding penicillin, are inaccurate. And yet, because of this fiction, clinicians are forced to prescribe suboptimal, broad-spectrum antibiotics. This drives up healthcare costs, it increases toxicity, and it fuels the global crisis of multi-drug-resistant organisms. Today, we're debating the protocols for delabeling these patients.
It's a heavy topic because it sits right at the intersection of statistical probability and, well, individual catastrophe. You call the list a fiction and, looking at the population data, you're right. But for the individual patient who had their throat close-up 30 years ago, that list is a shield. I come at this from the cautious, safety-focused perspective. I worry that in our rush to clean up the electronic medical record, we might be trivializing the immense biological complexity of the immune system. The question isn't just whether the list is wrong, it's whether we can prove it's wrong safely without accidentally killing the patient we're trying to help.
That is the tension. I'm arguing for a proactive, aggressive approach to delabeling. I believe the long allergy list is an active harm to public health. We need to empower primary care and even urgent care providers to perform risk stratification and, in many cases, on-site direct challenges to remove these labels. We simply cannot let fear dictate clinical practice when the evidence shows that the vast majority of these patients can safely take the medication they need.
And that is where I have to, pull back on the reins. Yes, the lists are inaccurate, but the potential for severe, life-threatening reactions, things like anaphylaxis, or the truly terrifying severe cutaneous adverse reactions like Stevens-Johnson syndrome, it just necessitates extreme caution. My stance is that while we should absolutely evaluate these allergies, we cannot treat it like a simple administrative task. Testing, particularly for moderate to high-risk patients, must remain the domain of specialists. The primary goal is do no harm, and sometimes that means leaving a label in place rather than experimenting on a patient in a clinic that isn't equipped for a code blue.
I see why you emphasize the safety net, but let me frame the harm differently. When we leave a false label on a chart, we are not strictly doing no harm. We are committing a distinct type of harm. We are denying that patient the first-line therapy. Let's look at the position clearly. A drug allergy label is often a complete misnomer. The source material is very clear on this. Many of these entries are simply side effects, nausea, headache, diarrhea. Those are not allergies, they're intolerances. Or they're remnants of a childhood viral rash that was misattributed to amoxicillin 20 years ago.
I agree that obvious side effects shouldn't be on the allergy list. That's low-hanging fruit.
But they are on the list. They are everywhere. And the consequence is that when that patient comes in with sepsis or severe pneumonia, the clinician looks at the screen, sees penicillin allergy, and skips the beta-lactams, the penicillin family. They move to broad-spectrum alternatives like fluoroquinolones or vancomycin. These drugs have higher toxicity profiles, they're more expensive, and they breed resistant superbugs like C. diff. The protocol we're reviewing explicitly states that over 90% of patients labeled penicillin allergic tolerate the drug after formal evaluation. My position is that the electronic medical record must be cleaned through active inquiry. We cannot just let these lists sit there, gathering dust and forcing bad antibiotic stewardship.
I'm not disputing the 90% figure. It's a powerful statistic. But I just don't buy that the solution is aggressive testing in non-specialist settings. We have to look at why those labels are there in the first place. Patients aren't lying. They aren't making this up. They experience an adverse event that was frightening to them. Maybe it was hives, maybe it was angioedema, swelling of the face or airway. You mentioned active inquiry, which is great, but biology is, it's messy. True IgE-mediated allergies can cause anaphylaxis in minutes. If you encourage a culture where every primary care provider feels pressure to clean the list, you risk overlooking the nuance of that history.
But are we respecting the history or are we being paralyzed by it?
We are respecting the mechanism. If a clinician incorrectly delabels a patient who actually has a history of a severe delayed reaction, something like toxic epidermal necrolysis where the skin actually detaches, the results can be fatal. You can't fix that with a shot of epinephrine. My position is that while we need to address the inaccuracies, the standard of care needs to lean heavily on referral to allergy and immunology. We need experts who understand the difference between a viral rash and a delayed hypersensitivity reaction.
That brings us directly to the physiology of this problem. You're talking about the biological mechanism, so let's dig into that. The core argument for delabeling isn't just that the original entry was a mistake, though often it was. It's that the immune system changes. The source material highlights a crucial fact. IgE sensitivity diminishes over time.
Let's just clarify IgE for the listener. We're talking about immunoglobulin E.
Right. IgE is the antibody responsible for the immediate, explosive reactions. The hives, the wheezing, the anaphylaxis, it's the lock and key mechanism. But the body doesn't keep those keys forever. The data shows that a true penicillin allergy often disappears after 10 years. The immune memory just fades.
That is true for IgE, yes. It wanes.
Exactly. So the list is wrong, not necessarily because the patient is lying or the doctor made a typo, but because the biological reality has shifted. If we have a patient whose reaction was 15 years ago, the likelihood of them still being allergic is incredibly low. Distinguishing intolerance, like the GI upset from opioids, from true allergy is step one. But step two is recognizing that even a true allergy from 2010 might be a no allergy in 2026. We are treating the medical record as a static stone tablet when it should be a living document that reflects the current state of the immune system.
I come at it from a different way regarding the timeline. You're focused on the waning of IgE, which is the immediate reaction mechanism, and that does fade. But I need to highlight the danger of the non-IgE-mediated reactions. These are the delayed reactions. They happen days, sometimes weeks later. We're talking about maculopapular rashes or contact dermatitis. These don't follow the same waning rules as IgE. They're T-cell mediated. The memory there is different. It's more stubborn.
But most of those delayed rashes are mild, are they not? A maculopapular rash is essentially a bumpy red rash. It's annoying, but it's rarely dangerous.
Many are mild, yes, but the history is often muddy. Distinguishing between a viral rash attributed to antibiotics, which happens all the time in kids, and a true delayed hypersensitivity requires clinical nuance that a busy urgent care provider might lack. If a patient says, "I got a rash 3 days later," and the provider thinks, "Oh, it's been 10 years, IgE wanes, let's give it a try," they are applying the wrong physiological framework. They are applying IgE logic to a non-IgE problem. And if that patient actually had a T-cell mediated reaction, re-exposure could be systemic and miserable. The nuance is everything here.
I appreciate the distinction, but I think the protocols we're looking at actually account for that. This leads us to the concept of risk stratification. We aren't suggesting we just give penicillin to everyone willy-nilly. The protocol champions a structured approach to separate the signal from the noise. We identify low-risk patients. These are people with a vague childhood history, reactions more than 10 years ago, or, non-immune systems like headache or nausea.
And what is your proposal for them? Because this is where the rubber meets the road.
The proposal, and this is supported by the source material, is that these low-risk patients do not need to clog up the waiting list of allergists, which can be months long. They are candidates for direct delabeling or a direct oral challenge. This means, in the clinic, giving them a single dose of amoxicillin, often 250 or 500 milligrams, and observing them for 60 minutes. The evidence cited is compelling. Reaction rates in these low-risk challenges are around 1 to 2%, and they are almost exclusively mild cutaneous reactions. It's a rash. It's not a catastrophe.
That sounds efficient on paper. But let's talk about the logistics of on-site testing. You're suggesting this happens in primary care or even urgent care. The protocol is very specific. On-site testing is only appropriate if the clinic has trained staff, emergency readiness, and validated testing methods.
Most clinics have epinephrine and basic airway management. That is standard.
Having an EpiPen in a drawer is different from having a team ready to manage a crashing patient. I push back on the safety of direct challenges in settings without full resuscitation capabilities. And it's not just the equipment, it's the decision-making. There is a moderate risk category mentioned in the material, hives or rashes that occur more than 24 hours later. This falls into a gray area. If a primary care provider misinterprets a moderate risk as a low risk and proceeds with a direct challenge, they are walking onto thin ice. These moderate patients must be referred to allergy and immunology. My fear is that by pushing direct challenge as the solution to the long allergy list, we blur the line between low and moderate risk.
I think you're underestimating the utility of validated tools like PenFast. The protocol specifically mentions this. It's a clinical decision rule that allows clinicians to objectify that risk.
Explain how that works for the listener.
It's a scoring system. You get points for risk factors. 5 years or less since the reaction, 2 points. Anaphylaxis or angioedema, 2 points. Severe cutaneous reaction, 2 points. Treatment required, 1 point. If the score is less than 3, the risk of a positive allergy test is less than 5%. It turns a subjective, I feel nervous, into an objective, this is statistically safe. We can't let the fear of the gray area prevent us from helping the black and white cases. The low-risk group is the majority. If we can delabel them on site, we free up the specialists for the complex cases you're worried about.
That's a compelling argument for efficiency, and I do like PenFast as a tool. But have you considered the third rail of allergy testing? We need to talk about SCAR.
SCAR is the hard stop.
Severe cutaneous adverse reactions. We're talking about Stevens-Johnson syndrome, or SJS, toxic epidermal necrolysis, TEN, DRESS, and AGP. These are not just rashes.
Agreed. These are absolute contraindications.
But let's paint the picture so the listener understands why I am the dissenter here. In SJS and TEN, the immune system attacks the skin and mucous membranes. It causes blistering and peeling. It's essentially a burn from the inside out. It can cause blindness, organ failure, and death. These are immune-mediated, but they are not IgE. They are T-cell delayed reactions. And here is the crucial distinction. Unlike the waning IgE allergy you rely on, these do not go away. They are permanent. You never re-challenge these patients.
I completely agree. The protocol is explicit. Never re-challenge SCAR.
But the history is often vague. That's my nightmare scenario. A patient comes in and says, I had a bad rash with bubbles 20 years ago. That bad rash with bubbles could be a severe viral exanthema, totally harmless, or it could be early SJS. If a well-meaning clinician in a rush decides, oh, it was 20 years ago, let's try a direct challenge, they could kill the patient. Re-challenging SJS is much worse than the first time. It happens faster and more severely. I worry that an aggressive delabeling culture might accidentally override these life-saving warnings in the chart. We're encouraging people to doubt the list. And in 99% of cases, doubting the list is good. But in that 1%, doubting the list is catastrophic.
I see the risk, and it is a grave one. But we have to weigh it against the certainty of harm from broad-spectrum antibiotics. We are balancing a theoretical risk of SCAR against the guaranteed risk of superbugs and toxicity. The protocol offers clarity here too. It distinguishes between mild delayed rashes and SCAR. A mild maculopapular rash is not SJS. SJS involves mucosal membranes, the eyes, the mouth, and skin pain. The protocol states clearly, mild delayed rashes do not require lifelong avoidance. We can't treat every rash like it's SJS. That is paralyzing medicine. The goal is to identify the red flags, mucosal involvement, skin pain, blistering, and separate those from the I got a bit itchy crowd. We can't let the specter of SJS prevent us from delabeling the 90% of low-risk patients who are currently receiving second-rate care because of a bad rash label from 1995.
I suppose my concern is interpretation. You trust the system to distinguish those red flags accurately every time. I am more skeptical of the system's ability to capture that nuance in a 15-minute appointment, which leads me to the systemic solution. Who should be doing this? Because if we get the who wrong, the how doesn't matter.
This is a key part of the debate. The protocol discusses emergency antibiotic decision-making. When a patient needs antibiotics, let's say for a sepsis risk or preoperative planning, we can't wait 3 months for an allergist appointment. I argue that urgent care providers and primary care providers can and should act.
Act how? By referring or by testing?
By referring if they can't test, but testing if they can. Look at the hierarchy of antibiotics. If someone is labeled allergic to penicillin, the next best option is often a cephalosporin. The cross-reactivity there is very low, yet people are terrified of it. If an urgent care provider sees an allergy list blocking immediate care, they should be empowered to initiate the referral or, if it's clearly low risk, using PenFast, perform the challenge. The goal is to unblock medication access. If we treat the allergy list as a specialist-only problem, it never gets fixed because the specialists are overwhelmed.
I firmly prefer the primary care provider, the PCP, as the gatekeeper here. Urgent care is episodic. You treat the street, you patch them up, they leave. Allergies evaluation requires follow-up. What if they have a delayed reaction 3 days later? The urgent care doctor isn't there. They're on to the next shift. The PCP handles chronic issues and long-term follow-up. Plus, insurance often demands it.
But the PCP is often the one who perpetuated the list in the first place by simply copying it forward year after year. The copy forward button is the enemy of delabeling.
That's why the standard referral language in the protocol is so critical. It isn't enough to just write refer to allergy. It must specify why. The language suggested is history suggests possible intolerances. Request formal allergy evaluation. A referral is safer than an on-site guess. But here is another systemic issue: documentation. Let's say your urgent care doctor does a challenge. They give the amoxicillin, the patient is fine. They say, "You're cured," and send them home. Does that actually make it into the permanent record? Or does the next doctor just see the old list again?
That is a data interoperability failure, not a clinical failure. But I take your point. If you delabel, you must delete the entry. However, looking at the protocol, it explicitly says urgent care may refer if allowed by clinic policy, especially when the list blocks immediate care. It's about utility. If I'm in urgent care with a nasty infection, and the computer says I can't have amoxicillin because my mom said I puked in 1990, I want that urgent care doctor to have the agency to fix that problem right now. I don't want a referral slip. I want the antibiotic that works.
And I want you to be safe. Start the process, sure, but the standard referral language frames the problem perfectly. Allergy labels restrict optimal therapy and may increase risk. We agree on the problem, but I want the listener to understand that delabeling isn't just erasing a line of text. It is a medical intervention. And like any intervention, like surgery, like prescribing, it has risks.
And I want the listener to understand that maintaining the label is also a medical intervention, one with proven negative outcomes. It is an intervention of omission.
That is a fair counterpoint. Inertia has a cost.
Let's look at the convergence here, because we aren't actually that far apart on the science. We both agree, and the source material supports this, that the long allergy list is a liability. It is cluttered with side effects like nausea and headaches that should be removed immediately. There's no debate there.
Agreed. If it says opioids, nausea, delete it. That is not an allergies. That is pharmacology. That is the drug doing what the drug does.
And we also agree that the high-risk histories, the anaphylaxis, the blistering skin conditions like SJS, those require specialist management. No one is suggesting we cavalierly challenge those patients in a strip mall clinic.
Absolutely. That is the third rail. We do not touch it. If there is mention of blisters, skin peeling, or mucosal involvement, that label stays until an expert says otherwise.
So the tension really lies in that massive middle ground, the low to moderate risk patients. I believe the default stance should be active investigation. We need to normalize the direct oral challenge for low-risk patients as a standard part of primary care, just like we check blood pressure or blood sugar. It's a public health necessity for antibiotic stewardship. We're running out of effective antibiotics, and we are wasting the ones we have because of bad data.
And I maintain that the default should be caution. The nuances of delayed reactions, the difference between viral rashes and drug eruptions, and the absolute requirement for emergency readiness make me hesitant to turn this into a routine procedure outside of a specialist office. I fear that in our zeal to fix the list, we might miss the warnings that actually matter. But I will concede this. The current system of ignore it and prescribe vancomycin is unsustainable.
It's a balance between safety and efficacy. But ultimately, the allergy list cannot remain a static historical record. It is a clinical tool that requires maintenance, whether through referral which you prefer, or direct on-site testing, which I advocate for, we have to clarify these labels.
I can agree with that. The most dangerous list is the one that hasn't been questioned.
Exactly. And for our listeners, this is a call to look at your own medical record. Is that allergy from childhood actually preventing you from getting the best care today? It might be time to ask the question.
Just make sure you ask it to a doctor who knows the difference between a side effect and a warning sign.
That concludes our debate for today. Thank you for listening to The Debate.